Thank you very much for the invitation. Toshiba asked me what we can do with neurointerventions and how far we can go with your neurointerventions. We have a very simple device like this here. This is my room. It's a monoplane Infinix-i 3 with a very big screen where you can do everything on this. We do with this device also everything, also all the neurointerventions, spinal, and also the cerebral interventions. What is important for Infinix and also an AngioSuit is that you have a good fluoroscopy. A good fluoroscopy because you have to be very quick in some cases. In some cases like this, can I show if my video works? You see here it's a very nice aneurysm. What we didn't see on the video is that there was a rupture of this aneurysm. I can show you here. You see a rupture of an aneurysm during the examination. That's why you have to have a very good fluoroscopy, a very handy device, and that you can work very quick with your devices. We did it here, a coiling in 5 minutes. And you see here the coiling afterwards. The patient went well afterwards, and you can control it with low contrast imaging like here. The pictures are not so good because the patient was moving, everybody was working on it, but you see very well where the bleeding is, where the bleeding and the contrast media is in the lateral ventricles, and due to the ventriculostomies, she survived it, and he hadn't a very high intracranial pressure. But that was one of the examples we can do with the Infinix-1 to see how quick we can work and that we have a very good fluoroscopy. Here is another example, also normal aneurysms we do here. That's a normal aneurysm with a normal 3D reconstructions, and you see there is a big blebs on the lower part of this aneurysm. And you can see very good in the 3D road mapping that we were working into the rupture site, and then when we advance our coiling, that's not so good, then we can redraw it very, very quickly. So the fluoroscopy must be very nice, otherwise you have some problems here. And that was the results of this patient. Aneurysm approaches, we have a lot of aneurysm approaches each year to do, and that's why we have here an example of a normal aneurysm approach. But you can have also very nice workup of this aneurysm. You can do a volume rendering, a maximum intensity correction, and you can measure everything out what you want. You can have the volumes, you can have also the size of the ostium of the aneurysm, and you can turn it in all ways to see a very nice ostium of the aneurysm so that you can be involved with a lot of catheters and coils inside of the aneurysm. Also the control afterwards, when you fill it up, there's not so good filling here, there's the first basket, but afterwards you have a very nice fill up of the aneurysm, but there is still a remaining neck size, and then you can control it with 3D here, and you see there's a lot of remaining space in the aneurysm. When you fill it more and more up until everything is finished and everything is closed, then you can recontrol it, and then you see that all the aneurysm is here gone and everything is closed. Then you have also other purpose and other material. Here it's a a double aneurysm. You saw it here very quickly. You can do it again. And then you see posterior and anterior aneurysm. And the approach is sometimes difficult, and that's why we have also introduced here the 3D road mapping. And that's the 3D road mapping where you can advance very nicely your catheter inside. When you work up the posterior aneurysm is always done, but you can advance very nicely with your catheter until the aneurysm here in the front of the ACOM. Also, during the workup, you can move your body, you can move the patients, you can move the screen and each side, and then the 3D road mapping is following you. You see, even you can zoom it also to see it exactly where you've been. And that's then the results after. That's a good consolidation of the both aneurysms. So aneurysm coiling is nowadays a standard in our hospital. There are few aneurysms were clipped, and that's why we need a very good resolution to see that the aneurysms are very good done and very good closed. And also that you see here there's a rupture site. You can make the measurements here. Afterwards, you can do a very nice basket, and if you see this picture, there's a nice basket, and here there's a rupture site. And at once there was a collapse of the coils through here, the rupture site, and then it started to bleed even after 3 or 4 coils inside. That you have to see. You have to see that there must be a good resolution so that you can quick coil everything closed, so that everything is closed. Also in stroke, the last time it's a very big issue everywhere in the country, also in Belgium, that stroke is involved in the interventional market because we can do a lot of things with stroke. Here is an older lady of 85 years old, and you see this, the media is completely closed. And then we installed here a stent, solitaire stent inside of the media, and it's also still closed, but started up to open it. And when we withdraw the coils, then you see that everything is open. After 1 hour, the patients went well, and the hemiplegia disappeared. Also here in AVMs, you can do very nice workup with the Toshiba. Here's a nice AVM and simple AVM of the anterior part. And there's a very nice nidus. We can see the workup is very good done with the aneurysm, with the angiography. And when you see here, then you have to visualize very good your catheter inside of the AVM. And when you glue it, then you have at the end this result that everything is closed and that the AVM is still gone, but the vessels are still open. The workup for normal deeper and AVMs by this young guy from 20 years old is also very good done with the Toshiba in this 3D imaging. Also in the 3D you can see the very nice feeders who's coming up into the AVM, and it's from the lenticular and AVMs was coming to the AVM. The workup is very nice, also done with this device. Stenting intercranially is one of the newer issues here in our department. And you see here, we did here 3 aneurysms already, but this was dysplastic arteries. And this dysplastic artery we have to stent because there was a regrowth here of your aneurysm, of your posterior aneurysm. So we can see this regrowth here. There's a new aneurysm there, and there's a third coming up there. Nevertheless, we did already 3 coilings there. So the only thing we can do is to stent everything so that the native vessel will be very good sealed. When here you see there's this stent is coming loose from the catheter, and when this loose, then you can go further and to fill up also the end of the aneurysm here. I can show you that we were with 3D road mapping, 2D road mapping. We advance here the catheter inside through the stent, and we fill up like here the whole aneurysm. And that's the final results. There is a stent inside, and the stent inside, and also the catheter was withdrawn, and we see the regrowth was filled up with coils. Covered stents, we use it sometimes, and there's a particular case here. There was a Moya. He was an hemiplegic young guy of 21 years old, and you see there's only one side branch left here who was feeding the whole media, and it's filiform from 1 millimeter. When we work it up in the side view, there was even smaller. Then we put here, that's why we showed you a very nice covered stent in crossover therapy here, and there you see there's the deployment of the stent, and afterwards there was a good deployment, but afterwards we dilate everything, and then you see there's a good dilatation of 4 millimeters of the stent, and the media was recovered, the patient recovered totally from the hemiplegia. So we go quicker, further and further with our stenting, with our combination therapies. And the therapy here I show you is a media aneurysma with the rupture site above the aneurysma of the media. Here you see the rupture site, and you see that all the vessels who are inside of the aneurysma were involved in the aneurysma. So you can turn it also here on a maximum intention projection, and you see here the rupture site. Also in the beginning you saw the ostium of the aneurysm, and all the vessels were here incorporated in the aneurysm. What you can do, you try it here with 2 catheters to try it here to start with coiling, but you see that the coiling are dislocated and they advance in all the side branches. So we have to do it with 3 catheters, 2 balloons, and the third catheter inside of the aneurysm. Here you see there is a fill-up of the aneurysm with coils, with 3 modeling, 2 balloon modeling, and then afterwards we put 2 Leo stents inside, and everything was closed. That was the end result. Also CT control, and Toshiba, you can see very nicely the positioning of the stents, also the coiling, and also the close combination of the coiling and the stents. You can go further to go with flow diverters, combination therapy with stents, with coils, everything you want. And here I can show you a case of 21-year-old lady with a very massive aneurysm here and the base of the skull base on the MRI pictures. This was in T2 and this is T1 picture. You see here also a very big hole and a flow void during the examination. The 3D, the time of flight pictures are not so beautiful, then I can skip them. But when you make the first angiography, then you see here how big the aneurysm is. It's a fusiform aneurysm of the whole carotid siphon of the right side. And then to have a very nice magnification of your aneurysm, then you see there is here the siphon, and there's a very big fusiform aneurysm of the whole petrosic part, the cavernosal part, until the ophthalmic part. What can you do? In the times we close it up with a balloon, but nowadays we start to reconstruct everything. You have advanced your stent, your catheter here in the first time. That's one of the toughest things you can do, is to put your catheter inside and then to lose here a very large stent over the whole size of the aneurysm. You lose here, and you position a very big Leo stent, and here you see we positioned at the end also the end part of the Leo stent. But there was a problem by positioning it here. You saw it here in the beginning. There was a stent turning, evolving of the stent, so you have to see that also your device, your Toshiba device, also your Aneurysm can see everything, that you have a good visualization of your stent. Nowadays it's workable with this Toshiba device, and you see at here there is a stenosis of your stent, and you have to work up this. We work it up with a balloon to go inside the balloon, inside the stent, and to balloon it up. But every time we raise it up, it was a recoiling. It fell back to the normal state, to the stenting, to the stenotic state. So we have to put another stent. Here you see a reconstruction also on our Aneurysm. There was a good deployment of the stent here, but there was here a stenotic part of this very, very long stent. Thus we have to dilate this part. Here you see this inside, this is the balloon inside, and here is also the stent stenosis. This you can do with Aneurysm. Nowadays, these pictures, you don't have to remove the patient to another device. So we go inside. You see here the stenotic part of the patient, and then we wait 1 month because we have a luxation of the Leo stent. We let them ingrow into the aneurysm so that we can handle afterwards this stent here with another stent. And so we started up after 1 month to put a very big catheter through the stenotic side. We do it with a balloon combination. We try it up with a balloon, and when we deflate the balloon, we advanced then the big catheter until it reaches its end localization here in the middle of the aneurysm. And then we introduce through this big stent, big catheter, another stent. Here you see, you have to see this on a fluoroscopy, and then we can dilate everything with this balloon and to position a cardio stent inside the stenotic site. And that's the results that we see after dilating the stent here and the stenotic site. But when you see that, one moment, the videos are very slow here. When you put your contrast inside, and you see there's always remaining a contrast who is involving into the aneurysm, and the aneurysm isn't closed at all. So we have to put a silk and flow diverting stent, 2 silk flow diverters into the stent's side. So we have put inside here other stents to close up all the aneurysm. And you dilate the whole traject, so you're busy for more than 5-6 hours for such an experience. You see here this A silk stent is introduced at the end, not in the beginning, and you see this closed already, but the beginning there's still a leak to the aneurysm. And this is the end results. You have a very nice reconstruction of your aneurysm, of your vessel, and the aneurysm is closed totally. He's waiting, he's searching my video. But then that is the end. Also on the angio suit, you can make these pictures and to see if everything is okay, if the stent is good, suitable in the aneurysm, and you see the total thrombosis of the aneurysm and the good positioning of the stent. I can say that the patient went well. She doesn't have any complications. That is an MRI after the embolization, and you see very well that's the very good occlusion of the aneurysm. You can see it here also on the time of flight. There's completely occlusion of the aneurysm. Another total other work we're doing is a spinal work. Spinal work in our hospital is a very big issue, and we do a lot of vertebroplasty, cementing, kyphoplasty. And the last years we are involved with new devices like the spinal jack. And I can show you here, there's one fracture here, a normal type A fracture. On MRI, you can see it. Oh. You see, there's a fresh fracture from 2-3 weeks old. We're working it always up with spine jack. We introduce here the needle. You see this also on a normal angio suit. You can have a very nice picture on side and a lateral view. And then you introduce your dilator inside, your drill inside of the vertebral body. You can follow it very nicely. Then you have a stamp to open the whole drill hole. And then you introduce your stamp here for the spine jack. Here the two spine jacks are introduced here, one side, and now is coming the other side. There for you need a very good view, and then you open the spine jack and you see that the vertebral body is coming up. You screw it up like a jack, and now it's coming up very slowly. It's a little bit on this film, a little bit quicker done. And you see afterwards when the spine jacks are completely opened, then also the vertebral body is opened. You can measure it, you can see also the volumes, everything you want with the angio suit. And that's after the spine jack is opened at a good level, that is the same level as this size and the other size, then you fill the rest up with cement. Also good visualization is obligate because you have some leakages sometimes in front or in the back and intraspinally, so you have to be aware. If you don't have a good visualization, then you can't do it. If everything is filled up with cement, you see here that afterwards there's a good waist height reconstruction of your compression fracture. Here was 12 millimeter, and then afterwards you see it's 18. There was a good height reconstruction of the whole body, of the whole vertebral body. But also with this angio suit, you can do very good results with this. Okay, thank you.